So I'd like to introduce our two speakers. So we've got Dr. Iris Little. She's a pediatric endocrinologist at the Turner Syndrome Clinic in Cincinnati, and has been taking care of girls and women with Turner syndrome for about 15 years. And you can find her finding some good coffee and potentially exercising. And then also wanted to introduce Dr. Michelle Rivera, who is an adult and pediatric endocrinologist at UT Health Houston. She specializes in TS care and is a member of our TSS US Scientific Advisory Board. So, Dr. Little.
Hopefully my voice holds out. Since I'm far away from you guys, I'm a little bit sick, so I'm going to take this off so you can actually understand me. Dr. Rivera and I are going to structure this a bit around the new guidelines and the recommendations that were relevant to our area, which is the hormonal area of Turner syndrome. So some of this, if you guys were at the talk yesterday that I gave about the basics of Turner syndrome, are going to be, it's a bit of overlap, but I'm going to go a little bit more in depth into some of the things that I mentioned yesterday. So let's start to talk about growth in Turner syndrome. So what does growth look like? What's kind of the classic pattern of growth? And this is a paper growth chart that we used to have in clinic before most clinics went to electronic medical records, and we used to plot those points every time we saw somebody. But what this shows, so the top three lines, or the red lines, show kind of somebody's growth, typical growth for somebody who does not have Turner syndrome. So the bottom line is kind of the shortest end of normal, the middle line is the average, and then the top line is kind of the tallest end of what's considered typical for somebody without Turner syndrome. And then the lines right under that are kind of the spectrum of what we would expect for somebody who has Turner syndrome who was never treated with growth hormone. And so you can see that throughout a child's life, they are shifted down from kids who don't have Turner syndrome, even at 2 years of age, which is kind of what's on the very left-hand side of this graph. That's from 2 to 20. And we know that slow growth actually begins before that baby is even born. And so girls with Turner syndrome are a bit smaller at birth, somewhere between 300 and 1,000 grams lighter than a baby who does not have Turner syndrome, and about 1 to 2 centimeters shorter than average babies. And then the slow growth just continues from there. We know that the growth spurt in puberty is less impressive than somebody who does not have Turner syndrome. And then the average adult height ranges depending on what country you're looking at. In the US, we think of adult height for a woman with Turner syndrome who's never been on growth hormone is about 4'8". And so that's about 20 centimeters or 8 inches below average height. So what's the reason for this slow growth? We know that this is because of a specific gene that's on the X chromosome that's then therefore missing. It's called the SHOX gene. It's called the short stature homeobox gene, and one copy is entirely missing. And that's what leads the growth plates not to grow in a typical way. It can also, this gene being missing can also cause some of the issues that we see with the way that the skeleton changes as that girl ages. So, for example, something called a Madelung deformity, which is an issue with the way that the wrist grows. And I don't know why my photos aren't popping up. Sorry, I hope they don't pop up as after I click a few times. There's also an issue with the elbow, the way the elbows form, and that's cubitus valgus. And then there are some short bones in the hand. And then also scoliosis is much, much more common. And these are all related to that specific gene. And now, of course, they're showing up. Sorry about that. So this shows something called a Madelung deformity, which is also called a bayonet deformity. You can kind of see why. and this can sometimes cause a lot of pain and issues with motion of the wrist. This girl's elbows are showing what cubitus valgus is, so she's not bending her elbows. They're just naturally sort of not straightening quite as much as typical. And then this is that short bone in the hand that we sometimes see. This is also scoliosis. Most people, I think, know what scoliosis is, but it's a bend in the spine that sometimes just gets watched and sometimes needs surgery depending on how bad it is. So let's talk a little bit about why girls get picked up in terms of Turner syndrome. Like, why does some physician look and say, gosh, let's test for Turner syndrome? And this is from our population. And you can see the bars that I sort of highlighted there are the reasons that girls are picked up at different ages. So on the very left-hand side, you can see this is why girls are picked up before they're born. The next bar is why girls are picked up when they're babies. The third bar is why girls are picked up in childhood. And you can see this big sort of mustard-colored section is because of growth. So the vast majority of girls in childhood are picked up because they're not growing well. And then in the teenage years, there's a big proportion of girls that are picked up because they're not growing well. And then another proportion of girls, that's this lavender box, that's picked up for a combination of not growing well and also puberty not starting as we expect. So let's go through specifically what the guidelines say, the ones that are literally published, I think, a month and a half ago. And so the first recommendation that has to do with growth is that we recommend starting growth hormone early. And because we know, just like I mentioned, that growth failure, growth slowing starts very early, and we don't want to lose time for that kid. And so growth hormone can be offered as early as 2 years of age, and can be also offered when growth is really tanking. I will tell you personally, the youngest I have ever started growth hormone on a girl with Turner syndrome is 13 months of age, and she was already incredibly short and really falling off the growth curve. So, for us, when we look at this recommendation, we can also adjust based on that girl's growth, how severe it is, how much she's failing off the growth curve. And that also means that for a lot of girls, I'm watching their growth and I'm like, man, this doesn't look bad. We can hold off a bit longer, and we can wait until that girl is a bit older. The next recommendation that's in the 2024 guidelines is that we continue growth until that girl is nearly done growing. And so for us, what that means is that a bone age, which is basically just an x-ray of your left hand that looks at how open growth plates are. And there are growth plates all through a growing kid's body, but there's just a ton of them in your hand, so we have a lot of them to look at and be able to see what does this girl's hand look like? Does it look like a 14-year-old, or does it look younger? Does it look older? And how much time might that girl have left to grow? The other thing that we look at is how slow that girl's growth is, because eventually everybody's growth plates close, and eventually that growth is going to slow to a crawl, and then we stop growth hormone because we know that it's not going to have very much impact. The last recommendations in the guidelines is about the dose of growth hormone. And this is very close to what's always been the dose. It's kind of an educated guess dose about what we think works based on studies that have been done, for all these years in girls and girls with Turner syndrome. And then we can adjust the dose based on labs and based on how that girl is responding in terms of her growth. So the next recommendation in the guidelines is that we watch that girl's growth while she's on growth hormone, right? So at a minimum, we tend to watch them every 6 months. So most people that I see in my clinic, I see them roughly every 4 to 6 months. If I'm seeing them a little bit more often, it means that I'm a little more worried about their growth and they're not responding the way that I'd like them to. If I see them a little bit less often, it means that I'm fairly happy with how things are going, and that I don't need to keep such close tabs on that kid's growth. And then these are the labs. This is the next recommendation is about the labs that I mentioned. So we get something called an IGF-1 level, and that tells me how to individualize the growth hormone dose for that kid. So growth hormone in your own body is made by the pituitary gland, and it tells the liver to make a few different what we call growth factors. IGF-1 is one of them, and so we use that to our advantage. We get IGF-1 levels to be able to adjust somebody's growth hormone level up and down. And the idea is that we want to keep that level within a normal range for that kid's age, puberty, because this level changes depending on how old you are, depending on if you're in puberty, and we want to keep it in the normal range. And more importantly, you want to kind of keep it in the upper end of normal. And then this is another recommendation that was made, which is that we don't routinely add estrogens in the years before we expect somebody to be in puberty, because it doesn't tend to help somebody's growth. So how well does growth hormone work in girls with Turner syndrome? This is sort of just showing a couple of different studies. So one of them reports about 2 to 3 inches if you treat somebody for anywhere between 5.5 and about 7.5 years. The average adult height gain is a little more than 2.5 inches. So when I tell people this in clinic, what I say is you get about an inch for every 2.5 years of treatment extra to what you would have grown without growth hormone. So that means that most girls will get about 2 to 3 inches if we have a decent amount of time to use growth hormone to help them grow. And if you get treated with growth hormone, just either half or just a little bit less than can reach an adult height kind of within the quote-unquote normal range. And what we consider normal, anything above 5 foot is kind of quote-unquote normal for an adult woman. If you're not treated, that's considerably less, so somewhere between 5% and 15 or so % reach a typical adult height. So what are the things that bode well for somebody's response to growth hormone? And these are a little bit unfair. You'll see what I mean. If your height is taller before you started growth hormone, you tend to do better with your height, right? So, which doesn't seem exactly fair. If you have taller parents, so you have the benefit of all those other genes that have to do with how you grow, right? If you are younger when growth hormone is started, meaning we have more years to treat you, we can do better with adult height. And that's because this helps prevent that growth failure, the growth slowing that we see if we get ahead of it and we put somebody on growth hormone before that happens. The longer you have on treatment, the better we can do, especially before puberty. So I will tell you, I think I can't count how many times I have somebody come into clinic with Turner syndrome or for another reason that they're not growing well, and the family will say, oh, we wanted to come because she's starting puberty, and we know that's kind of the window. And I'll sort of say like, well, actually, what really counts is all of those growing years before you start puberty, because once puberty starts, that clock is ticking on those growth plates to close. So ideally, we would get at least 4 years of growth hormone treatment before puberty starts. So let's talk a little bit about, I mentioned this when I talked about one of the guidelines, the growth hormone dose, again, sort of based on why we're treating somebody and their weight. So we start with kind of an educated guess, start somewhere between 2 and 6 years of age typically, and we adjust the dose, right? We already kind of mentioned this, and we keep that IGF-1 within normal or really just barely above. Sometimes I'll tolerate that as well. And we stop when the bone age is about 14. This is kind of a review of what we've already talked about, or when the growth is very, very slow. Let me just quickly mention some other treatments that either have been available in the past or on the horizon for treatment. Oxandrolone is no longer FDA approved, so we don't use it. We used to use it in kids where growth hormone wasn't working as well as we would have liked. So you may have heard about this in the past. I think these estimates from other studies about how much it added I think most of us think it's probably on the generous side, and it had some side effects that a lot of us were uncomfortable with. So I will tell you, I am personally not distressed by the fact that it's no longer available. And then something that's on the horizon for girls and women with Turner syndrome is long-acting growth hormone, and there are ongoing trials using long-acting growth hormone in girls with Turner syndrome. We're a site that's using this under a research protocol. It's been approved, long-acting growth hormone for a few companies has been approved for girls and boys with growth hormone deficiency, meaning they don't make enough growth hormone. And it seems to work quite well. And for those kids, it seems to give them a height that's probably about equivalent to using growth hormone daily, right? Because growth hormone is a nightly injection, as most of you know. And so this is kind of just, it's getting a little bit, making that treatment a bit easier because you only have to give that injection once a night. So I'm excited for the prospect of that and actually having more options, right? Because really up until now, our only real viable, effective option has been daily growth hormone. So I think it'll be really cool when we can offer more things to families that hopefully will work just as well. So this is an important thing to talk about because sometimes growth doesn't go well, right? So, and I'm looking at somebody's growth chart and I am saying like, you know, this isn't the best growth I've ever seen. I wish it was better. And what always triggers in my head is, why aren't things going well? And so you always have to be thinking about, is there something else that I'm not accounting for why this kid's growth is not as good as I expect? And so we always look at, can we optimize that growth hormone dose? Can I increase it? Do I have room to safely increase that growth hormone dose? Is weight gain, meaning like they're not gaining weight well enough to even fuel growth? So, you know, there are kids where their weight gain is just piddly for a number of reasons, right? ADHD medications, they're not a good eater, you know, for a number of different reasons. And that can affect how well growth hormone works, and it can slow their growth. We definitely think about thyroid problems, celiac disease. So these are things that I'm screening for when I look at somebody's growth and it's not as good as I want it to be. There are rarely other things that can happen in addition to Turner syndrome in the same kid, right? So I have a few patients that I can think of off the top of my head that have Turner syndrome plus another genetic change that affects the growth of their skeleton. And because of that, their growth is not the same as somebody who only has Turner syndrome as the reason for their slow growth or short stature. And then the last reason that I'll talk about is just not taking growth hormone consistently, right? So, you know, if you think about it, even if you miss 1 or 2 doses a week, that's a pretty big chunk of the effect of growth hormone. So, you know, that's something that we talk about in clinic as well. The best you're going to do is getting it in every day, right? Which is also something that I'm hopeful that weekly growth hormone can help with, right? Because the reality is that everybody is not great about taking medications. If you look at studies in adults of how consistently they're taking their medications, it's pretty atrocious. And I will tell you, I am pretty terrible about taking my own medications. So like, I don't judge when people come, but you know, we try to think of like, what are strategies that we can help to get this into you every day so that we can do the best that we can possibly do for, you know, for a medication that's a lot of investment of time and effort, right? And then the other thing that we think about is inflammatory bowel disease. So that would be ulcerative colitis or Crohn's disease, which is a little bit more common in girls and women with Turner syndrome. All right, let's very quickly go through side effects because I don't want to eat up all of my speaking partner's time too. So side effects of growth hormone are quite rare. One that we talk about is an increase in the pressure in the fluid around the brain. Those kids will have headaches and changes in their vision. So that's one of the things that I always say when I start somebody on growth hormone. If that kid is having progressively increasing headaches, meaning more often, more severe, I want to know about it, and changes in their vision, because this is a side effect that can happen. And when we take somebody off of growth hormone, as long as we catch that side effect early, it can reverse itself. So we really do want to know early about that side effect. The other one that we think about, I apparently didn't time my animations right, sorry. So the other one that we talk about is basically the top of the thigh bone, which is the femur, that growth plate kind of separates, and the top of that kind of ice cream cone, and I have a picture of that here, slips off. When this happens, it is a big deal. It's a surgical fix that has to happen, but often for this problem, we can restart growth hormone after that person has gotten their hips pinned by an orthopedic surgeon, and they do okay. Again, both of these side effects are needle in a haystack complications. They are very, very rare. So just to finish that last slide, anybody who's on growth hormone who has knee or hip pain, because sometimes kids can feel that hip issue happening as knee pain. So we don't want to forget that if anybody who's having hip or knee pain, they need to call us, and we sometimes will get x-rays depending on what that family is telling us. This is a really quick guideline about hypoglycemia. So we know that in babies with Turner syndrome, they're at higher risk of having low blood sugars at birth. And so this guideline is new in the 2024 guidelines, that we need to check blood sugars in little babies with Turner syndrome if we know, obviously, that they have Turner syndrome at birth. And the reasons for this are for a lot of different reasons. So, babies can be premature. They're at risk for low blood sugars. If they are small at birth, so that's called small for gestational age, they're at higher risk for low blood sugars. If they're not feeding well, which is definitely more common in girls and babies with Turner syndrome. If they have heart disease. And then there's a rare condition where the pancreas actually makes too much insulin and drives down that blood sugar, but there is a higher risk of that in babies with Turner syndrome. And I can think of 2 patients that I take care of with both of those problems. So with Turner syndrome plus that they make too much insulin within their own body. And so like the guideline mentioned, we check sugars after birth, and then within the first 48 hours to make sure that those blood sugars are normal and stay normal, because blood sugar is so important for keeping that brain healthy and feeding the brain. And then we also pay attention to symptoms that could mean that that kiddo has low blood sugars. So that would be shaky, sweaty, poor feeding, and then seizures, of course. Let's very quickly talk about bone health. So the new guidelines recommend healthy lifestyle. So that means taking in enough calcium, vitamin D, doing weight-bearing activities, because the more kind of stress you put on your skeleton, the more it actually remodels itself and keeps itself healthy and strong. And that people are started on estrogen at the right time and continued on estrogen for the right amount of time, and that they don't stop it before their doctor says they should. And then we routinely screen for vitamin D deficiency, so we get labs to make sure that that girl has taken enough vitamin D and that we don't need to supplement her. And then we also check for how strong the bones are with something called a DEXA scan. And that usually is when we're done with sort of going through the process of us starting and finishing puberty, and that woman at that point is on adult doses of estrogens. And then there's a second recommendation to sort of use DEXA scans to monitor bone mineral density over the course of that woman's life, but particularly in high-risk women. So this is what a DEXA scan looks like. I'm not going to spend a ton of time here because, I think I'm running out of my time. But osteoporosis and bone breaks are more common. And like I said, using estrogens and staying on estrogens, super, super important to keep bones healthy. Getting enough vitamin D and calcium, and also that weight-bearing activity that we talked about. Very important. Then we're checking bone strength after puberty is kind of finished. But the key to DEXA scans is that you have to adjust them for that person's height, because if you do not, it makes the bones look quite a bit weaker than they actually are. and it's not advancing. Give me a second. Okay. Very quickly, thyroid, measuring thyroid hormone at least every year or two, starting at age 2 was part of the new guidelines. And a little less than a fourth of girls and women with Turner syndrome have hypothyroidism, meaning they don't make enough thyroid hormone, and that's something that we want to know about and treat because it's actually very easy to treat when we find it. And then there's a small proportion of girls who actually make too much thyroid hormone, that's Graves' disease. And this is especially true, I don't know if you guys went to the genetics talks, but in somebody who has something called an isochromosome. I'm not going to go into it, but if somebody's curious, I'm happy to talk about that later. And then, like we mentioned, checking a TSH every 1 to 2 years. So I'm going to hand the mic over to Dr. Rivera, and we'll be happy to take questions after she's done.
Thank you. Good afternoon. So I'm going to talk a little bit more about the reproductive system and then briefly touch on metabolic disease, specifically the guidelines towards monitoring for diabetes itself. So we'll talk a little bit about how we go about inducing puberty, what are the different strategies that we have for replacement of estrogen, how that may be helpful and beneficial, and also something we don't really talk about too much is the fact that women with Turner syndrome are also deficient in male hormone production to some degree. We'll briefly touch on fertility and, again, as I said, the diabetes guidelines. So we know that failure of the ovaries is seen in the majority of women with Turner syndrome. So this is believed to be due to dysgenesis of the gonads, and this can start very early in our fetal life. Usually by week 18, we're noticing that there's loss of the oocytes, and oocytes are basically the eggs that are in the ovary. In female fertility, we are born with the number of eggs we will have for our lifetime, and typically over time, those cells do die off naturally. In Turner syndrome, there's an acceleration of that natural loss. Unlike men who will make new sperm as they go through life, we are born with a finite amount of these eggs. The tissue of the ovaries themselves are replaced by essentially what's scar tissue. It's a stromal tissue, and that disrupts and degrades the eggs as well as the cells that support the function of the eggs, which is called the structure itself is called the follicle. So, despite this, though, about more than a third of women with Turner syndrome will have some degree of puberty. Typically, this is much more common, about twice as likely if you have a mosaic karyotype that includes cell lines with 2 X chromosomes. About 20% may actually even progress to having menses or periods. But typically, there is early onset of menstrual irregularities and premature ovarian failure, usually within the first 3 years. Rarely, we may see individuals who actually will have menses for a good prolonged period of time. Sorry about the slides. Didn't come back. It's a little bit off center, but so what are the signs of puberty that we're looking for? Typically, what we're looking at when we talk about where an individual is in terms of their Tanner staging, we're looking at the different stages of both breast and pubic hair development. And we try, as we're replacing or inducing puberty, to mimic the timing that we would typically see in a child who's doing this spontaneously. So Tanner 1 is someone who is not having any signs of puberty. Tanner 2 breast is usually a breast mound that's more or less contained to the area of the areola. And then as it expands, we would consider that a Tanner 3. And then once we see what we call a secondary mound, meaning the nipple area is a little bit almost like ice cream scoops, 2 scoops of ice cream, kind of that sort of distribution, that would be a Tanner 4, and then it smooths out again to a mature Tanner 5 breast. And then the pubic hair development, that's more or less along the lines of initially we see body hair along where the labia meet, and then it becomes a triangle, and that triangle expands, and that's how we would stage the pubic hair development. So these are things that we are keeping an eye out for, because they can help guide us as to giving us signs and symptoms as to whether that individual is ready to start estrogen replacement therapy. There's a lot of variability as to the timing of onset of puberty, often related to our genetic background. So, for example, it's not uncommon for us to see Hispanic and African American children developing in puberty much earlier than our Caucasian peers. And so in that sense, we're trying to see, as we're speaking to the family and talking to the child, how, when is the proper time, and when is this individual's body ready for induction of puberty. So sometimes you may notice that there is a little bit of acne or body odor starting, and these are the times where you may want to start approaching puberty with your child and speaking to them about it, even if the actual timing of estrogen replacement is done a little bit later. Now, when we look at the way our body works, the ovaries receive a message or a signal from a portion of the brain called the pituitary gland, usually the anterior portion of the pituitary gland. And that makes the hormones that you may have heard your doctor talk about, LH and FSH. And those hormones signal to the ovaries to make estrogen. The ovary itself can make hormones such as inhibin B and anti-Müllerian hormone, which we can also use as measures of looking at how the ovaries are working. So LH and FSH will often give us an indication of whether or not the ovary is capable of making estrogen. But AMH, or anti-Müllerian hormone, gives us a little bit more information about whether that ovary or those ovaries have viable follicles, or whether the eggs are still there, or have they been replaced by scar tissue. Unfortunately, this process is typically ongoing and starts very early. So a lot of times when we are at an age where we would expect puberty to initiate or to start, that individual has already lost a lot of this function. The recent guidelines are, recommending that we start screening for some of these labs between the ages of 8 and 9 and do that yearly. And then levels of AMH are typically low when we are missing the follicular function, or the eggs are not functioning. So an AMH of level of less than 4 or is often undetectable, can definitely signal that the follicles or the eggs themselves are not there or no longer present. All of this is to help guide us not only in the timing of estrogen replacement, but also when to make the recommendation for that individual to talk to a fertility specialist as well. Now, we talked about what the blood work might look like, and I didn't explicitly say, but also in addition to having the high FSH and LH, the low AMH, we typically would find that the estradiol or estrogen levels are also low. In terms of ultrasounds, you may find that when we do ultrasounds of the pelvis, the radiologist is describing the uterus as quote-unquote infantile. And that's just a way of saying that it doesn't appear to have been exposed to estrogen. Therefore, it's continued to be a very small muscular structure, low in the pelvis. And that's kind of what they mean by that. As we expose the uterus to estrogen, it not only grows in size, it improves blood flow to that tissue, and then we start to see the lining of the uterus grow, which is where typically the egg is implanted. And so that's what gives the nutrients to the fertilized eggs. Oftentimes, you may also find that when you go through your ultrasounds, the radiologist the tech cannot find the ovaries. That doesn't mean they were never there. They have, it's rare for us to necessarily expect the ovaries to not have been created or to have been formed. It's more that they have been infiltrated with this sort of scar tissue, and they become very small and are very difficult to see on imaging. We also are dealing with the possibility of different karyotypes as we're talking about puberty and exposure to different steroids or estrogen and testosterone as we develop in puberty. Sometimes if you have Y chromosome material, there may be some gonadal tissue that is actually able to produce testosterone. And if that gonadal tissue is present and it's able to produce testosterone, then there's an increased risk of having gonadoblastomas. And most recently, the presence or the risk is about 12 to 20%. I feel like these slides are missing the bottom portion, but I think I'm missing a little bit of information there. But anyway, the presence of Y chromosome material, typically we used to say that we would recommend removing these gonads in all individuals with Y chromosome material. Now we are leaning towards a more conservative approach, especially in these newer guidelines. And the approach is more to weigh the risks and benefits in the particular individual. We know that the risk of gonadoblastoma increases after puberty, so it may be okay in that person to let them initiate or go through puberty if they're already starting to make some estrogen, or if they're having some function, if they have some function in those ovaries. Let them start or finish puberty and then remove them when they're no longer of use or when there's true evidence of complete failure of the tissue. So that will need to be individualized, whereas before we would just make a blanket statement, they should all be removed. Now we're sort of giving some leniency or some leeway for that possibility of maintaining those gonads to induce puberty. Now, if you have an individual who does not have Y chromosome material, then in their karyotype or in their genes, then we may need to look at whether they're producing testosterone or androgens in another tissue, because you can certainly have other health conditions, and we as endocrinologists do see patients who make male hormones in other tissues, such as the adrenal glands, and you can certainly have another health issue on top of the Turner syndrome that could contribute to that. So we should be thinking about other potential medical conditions, not just Turner syndrome or Y chromosome material. What are we trying to achieve with estrogen replacement? We typically associate estrogen with breast development, but it is very important for us to, as females, to receive sufficient estrogen for other functions in our body as well. So we are looking for estrogen to help with psychosocial adaptation, with the way our brain changes and develops. We'll go into it a little bit later, but there's also some evidence to suggest that it helps improve memory and other neurodevelopmental functioning. Secondary sexual characteristics, of course, are important, such as our breast development, and some of the sort of more feminine shape to our body is definitely part of that estrogen results, or the results of estrogen exposure. We talked about the uterus getting larger and creating that increased blood flow to that tissue, so that if in the future fertility options include, for example, perhaps having a gestation, carrying a pregnancy, whether it's through your own eggs or a donation of eggs, or a fertilized embryo, you have a uterus that's receptive to that fetus. And so it's important to help promote that health of the uterus as well. Estrogen, as Dr. Little said, is one of the main things that we would replace in order to help maintain our bone health. Maintaining higher doses of estrogen and estrogen replacement is going to help promote better bone mass accrual. And we continue to build bone into our third decade, so somewhere between our 20s and 30s. So even if you're completed your growth hormone therapy and you're no longer getting taller, even if you've then had puberty induction, now you're having periods, and say you're 18 years old and you're going off to college and you're thinking, okay, well, I've done my growth, I have developed my breasts, I have a feminine shape I'm happy with. Why do I need to continue to take estrogen? Why should I continue to take estrogen if that's going to make me have cycles or periods, which I definitely don't want to deal with? So all of these things, and especially bone health and maintaining that bone mass accrual, are going to be important reasons to maintain estrogen therapy. We know that it helps improve cardiovascular risk factors. We talked about brain development as well. And it also helps improve liver function. I think someone approached me a little bit earlier today about having slightly elevated liver function tests, and that's a fairly common finding in individuals with Turner syndrome. And we know that some of that can actually improve slightly with estrogen replacement therapy. So the goal is to mimic the normal progression of puberty growth, and to do that in a way that limits or decreases the side effects of estrogen exposure, which if we're too aggressive with estrogen replacement, we could potentially close the growth plates too quickly, and that's one of the things that we want to try to avoid with estrogen replacement. Now, delaying it too much or not using estrogen at all does seem to have a detrimental effect to bone health, uterine health, and also psychosocial development. So how do we go about using estrogen? There are to induce puberty. So there are lots of different formulations, and different countries even have slightly different formulations available to them. Here in the United States, we typically have estradiol, 17-beta estradiol offered to us in a couple of different ways. Usually it's transdermal patches, and a tablet form. Now, for puberty induction, we tend to prefer the transdermal patches because when we ingest estrogen, or the 17-beta estradiol, we make byproducts in our liver that tend to have negative effects on our lipids, our cholesterol panel, on some of the way we bind other hormones in our bloodstream, maybe cause a little bit more insulin resistance, and also increases our risk of forming clots. And so through the skin, we avoid giving the liver a big dose of estrogen that it has to deal with, and so we don't produce those sort of secondary hormones as we're breaking things down. So having said that, there's been a few studies on what the best dosing regimen would be. There's some studies through NIH and some other studies that have been done, through the years. However, the dose that's recommended is not a dose that we can actually achieve with a patch necessarily, like a full patch initially. So we've taken to, against our pharmacist's wishes, asking y'all to cut those patches into smaller pieces, and then using that to kind of slowly increase the dose and induce puberty changes. So you'll see us recommend things like cut the patch in fourths, use that, potentially even overnight for about 6 months, and then increase it to keeping the patch on your skin for the full day, then go to half a patch, a full patch, and so on and so forth. Oftentimes, your insurance might choose one for you, whether it's once a week or twice a week. We can work with either of those options. And then we just slowly increase the dose over the course of the next 2 to 3 years to try to mimic what a typical child would see in terms of their estrogen exposure or their estrogen production over that time frame. Typical adult doses for the patches are 50 to 200 micrograms per day, which also brings up issues with insurance coverage. Honestly, if I'm being completely honest with you, sometimes above 100 micrograms, we start to get a little pushback from your insurance because they don't understand why you need to be on such high doses of estrogen. So these are things that we may find as sort of barriers to using these types of higher doses. But up until about 100 micrograms, you don't typically have that issue. And then about 2 years after starting estrogen, we start to think about what other things does our ovary produce that we may need to replace that also helps us with our menstrual cycle, and that's actually the progesterone part of the equation. So going back to the estrogen formulations, we can also induce puberty with the estradiol tablets. Usually they come in 0.5 milligram or higher doses, but we can start with half of a tablet and start at doses of 0.25 milligrams daily and go up every 6 months or so. Adult doses are usually between 2 to 4 milligrams per day of the tablet form. So if we use either one of these regimens, we typically see people achieve that Tanner 4 breast stage about 2.25 years later. And that's pretty comparable to what a child would normally do, a young female would normally do spontaneously. So we feel like these regimens are mimicking pretty closely what we may see in a child without ovarian failure. Now, as we said earlier, you can certainly have male hormone production in other areas, so your axillary hair and your pubic hair, and some of those blackheads and acne and other changes that you might see in your skin and body odor, that isn't necessarily ruled by the ovaries. That function actually those are hormones produced in the adrenal glands, and that adrenal gland function is intact in individuals with Turner syndrome, so we don't typically see people have difficulty with that part of their puberty development. Now, some people are on growth hormone since they're a very small child, 2 to 4 years of age, and may be on medication for a good 7 years before we start talking about estrogen replacement. But for a lot of you start to see, or you've been diagnosed a little bit older, right? And so if you're diagnosed a little bit older, there's that question or that concern that if we give you estrogen, we could be limiting the amount of time you have to grow. So in that situation, we're really trying to individualize a little bit that care and trying to understand kind of where are you in that spectrum. Do you have growth plates that are still open? Maybe you have tall parents and you have a height that's, pretty good already. Maybe you have a karyotype that allows for you to have a slightly taller stature. And maybe your focus is really on feminization. Maybe you want to have more breast tissue and you're not so worried about your height. In that situation, we may be more aggressive with estrogen replacement and sort of focus on being a little bit quicker in that induction. But if you do have growth potential and everyone is on board with the idea of growth hormone and estrogen, we can certainly use them simultaneously to help promote improved growth. I think that's the majority of that. Okay, so we talked a little bit about the other hormone that's made in the ovaries called progesterone. And we do need exposure to progesterone to maintain the health of our uterus. The muscle of the uterus, if it's only seeing estrogen continuously without there being this other hormone called progesterone exposing that tissue to the progesterone, we can then develop or have a higher risk of developing tumors in the muscle of the uterus and even endometrial carcinoma. So our goal is to, again, mimic what is natural for a female to have exposure to. And so after 2 to 4 years of being on estrogen, we will introduce this hormone. This also helps regulate the timing of our menstrual bleeding as well as the length of our menstrual bleeding. And this is why we need to use progesterone. The guidelines this year were a little bit more specific about actually promoting the use of micronized progesterone versus medroxyprogesterone. So many of you may have been treated with other forms of progesterone over your lifetime. I think if you're doing well with your current regimen, you don't necessarily have to switch to micronized progesterone, but if it's something you want to try, that is certainly something you can discuss with your physicians. And the recommendation is to use it for 10 to 12 days a month. So there are a few different, if this isn't confusing enough, we've got different types of estrogen, we've got different types of progesterone. Now we've got different regimens. So you can give estrogen, for example, for 3 weeks out of the month, and then overlap that with your progesterone. And then you spend about a week where you don't have estrogen. You're mostly getting progesterone, and then you're off medication and you have your cycle. So you can kind of do those regimens. Some of you may be on that kind of regimen. And sometimes what we do is we give both continuously, and that tends to cause less bleeding, less menstrual cycle bleeding. But we typically reserve that for people who have already kind of completed their induction, because sometimes this can be achieved with combined oral contraceptive medications, for example. And so that makes it a little bit harder to push up your estrogen doses. And if you are somebody who's not as sensitive to the estradiol, you may not have achieved your peak bone mass. And so we're trying to sort of individualize care, where we use specific doses and try to achieve higher doses so that we can improve bone health. But then at some point, we may switch to combined therapy so that you have less menstrual bleeding. Now, if you are using oral contraceptive medications, the type of estrogen that's in those pills is called ethinyl estradiol, and that one is not recommended for puberty induction because it doesn't seem to have as good effects on the bone. Now, if you are using ethinyl estradiol, so oral contraceptive medications is typically where that's found, we would encourage you to try the higher doses of estrogen in those pills so as to continue to keep that bone health steady. So there are also other ways of receiving progesterone and estrogen. So some of our adult women might even prefer to decrease their menstrual bleeding even further. And one way that can be achieved is to, for example, use an intrauterine device. There are some intrauterine devices that are soaked in progesterone or that will have progesterone embedded in them so that is being released continuously into your system. And then you can use estrogen patches or estrogen pills to receive your estrogen that way. And this may be a way to help decrease menstrual bleeding but still receive both of your hormones. And then in some situations and in some countries, puberty induction and estrogen can be given intramuscularly as an injection. That's not typically something we do here commonly, but it is available as well. And so again, that last sentence, we talked about a lot of different ways of receiving estrogen, and we are always hopeful that you will give us feedback on why your regimens are working or not working, because we want to be able to give you the best experience possible, but we do understand that people can be very sensitive to different types of estrogens or combinations, and there are, actually dozens, of different types of oral contraceptives because not everyone responds the same to different formulations. And so if one regimen is not working for you, absolutely discuss that with your physicians because we would much rather continue to try to tailor things to what works for you and your lifestyle than that you just sort of give up on the whole process and don't take your estrogen at all. And so we talked a little bit about why we would prefer transdermal route. When we compare them, and there have been a lot of studies comparing getting the estradiol tablets versus the transdermal, there didn't seem to be too many differences in things like growth factor levels, bone density, uterine, the way your uterus responded to it, or even body composition, lipid panels. There were some differences, but they weren't necessarily statistically significant. But oral estrogen did seem to have a better HDL cholesterol. I think we've discussed the majority of this, but when it comes to different strategies of estrogen replacement or different dosing, like how do I know what dose of estrogen is ideal for you as a person? So we're looking at physical changes. So how has your breast development been? Are you maturing through your puberty as you should? What is happening with your blood levels in terms of how satisfied is your body with the amount of estrogen you're receiving? How high are your estrogen levels? Sometimes the type of estrogen that you're taking makes it hard to interpret the estrogen level, so you may notice that your physician doesn't even check some of these labs because it doesn't really make a difference to the way they're managing you. And that can be, for example, oral contraceptive medications that you can't often measure the estradiol reliably, for example. Another parameter we might use is ultrasound to look at how your uterus is growing, looking at whether that uterine stripe is there, how is that changing over time, and then the DEXA scan that we talked about earlier. Adult doses, again, we said about 2 to 4 milligrams of the oral estradiol. Patches would be somewhere above 50 micrograms, typical doses for an adult. And then if you're taking the oral contraceptives, we would probably guide you towards the higher doses of 30 micrograms of the ethinyl estradiol. So as you increase your estrogen doses, you may also have to increase your progesterone dose to help regulate your bleeding, your menstrual bleeding. And then we would want you to stay on estrogen replacement therapy until the age of natural menopause for us here in the United States would be somewhere between 50 and 55. And then I think it's important to understand that there have been some studies, cardiovascular studies that came out several years ago that do show that hormone replacement therapy after menopause can increase our risk of cardiovascular disease. So we should individualize that based on where we are at that time. What are our risk factors? Do we have congenital heart differences in our heart that are increasing our risk for a heart attack or a stroke? Where are we when it comes to our blood pressure and other parameters like our cholesterol and our diabetes status? And that would help guide our risk for whether it's favorable or not to continue on estrogen replacement therapy. We've talked a little bit about other benefits in terms of estrogen replacement, but we do believe that estrogen may have some positive effects on cognitive function and mood, as well as verbal and nonverbal memory. There are some MRI studies that sort of look at what our brain looks like as we go through puberty, and you can clearly see some differences in our brain structure and maturity as we are exposed to not only estrogen, but in males as well as they're exposed to testosterone. So there are some physiologic changes that come along with puberty. You may also note, for example, we talk a lot about transition of care in Turner syndrome, and sometimes it takes us a little bit longer to be more independent. And that could be to some degree the fact that we are inducing puberty, so you're sort of at the mercy of your medical team as to when you start to receive a lot of these hormone replacements, and that can affect how you perceive yourself. You may not be maturing because you're not being exposed to the sex steroids and having sort of the same timing of development as other individuals. So there's a lot to be said for trying to maintain or trying to induce these changes along with the expectations for that population and your peer group. So the ovaries not only make estrogen and progesterone, they do make testosterone in women. And so we know that any person who has ovarian failure will likely also have low levels of testosterone. And so testosterone plays an important role in several functions in women. And there have been some studies, specifically a pilot study, looking at giving women with Turner syndrome testosterone. There was a formulation that was given orally, 1.5 milligrams of methyl testosterone that is available here in the United States. And sometimes it's even available in combination with some estrogen. So it may be something to bring up with your physicians. But the exposure to male hormones may help improve reaction time, verbal memory, your your overall lean body mass, bone density, your libido, your cholesterol panel. and in sometimes also some cognitive functionality. So this is always, of course, fertility is always a topic that's very difficult and can, be very, it brings up a lot of emotions. And so as we're talking to our young women and families about what we're seeing regarding their ability to have fertility in the future or to have natural children in the future, this can certainly be an area that's very delicate. And so we want to be providing information to the family and the individual with Turner syndrome that's age appropriate in a way that they can understand. And these can be certainly difficult topics altogether. But also we want to be able to refer you to a fertility specialist as quickly as possible. And we should continue to offer access. So if initially you're not sure, you don't know, what you would achieve if your child is 8 years old, is that the appropriate time to talk to a fertility specialist? What would they even do? These types of things. So even just having an initial consultation just to kind of go through options can be very informative and also be able to kind of give you a guidance so that you know how to speak with your child or daughter or your teen as they age through this process. And if you change your mind and you want to go later, absolutely ask, because if you don't get that information or if you don't know what to do with it initially and you decide later on you want that information, absolutely ask, because we're happy to send you for that referral anytime. And of course, I think it's important to speak about all the different ways that we can form a family. Sometimes the people that we're closest to are not the people that we are related to, for many of us. So I think it's important to discuss other ways of having a family, including things such as foster care and adoption, and surrogacy and other methods. Now, if you have a heart that is healthy enough to carry a pregnancy, you still need to have assessments of your cardiovascular status before that pregnancy and during that pregnancy, so that we are sure to limit any potential complications of the pregnancy. There's a lot of fluid shifts and changes that happen during the pregnancy that could affect our heart health. And so any strain that increases strain to our aortas or our heart could potentially lead to significant deterioration of our cardiac status. So these are things that we need to know as we're progressing through. Lastly, we talk about metabolic disease because there's a lot of risk factors with Turner syndrome to sort of increase our risk for cardiovascular disease in general. So because of the short stature, we do face a lot of concerns about what's the ideal body weight and, changes throughout our lifetime. And it's difficult to maintain, BMIs that would be considered within the normal range. So it's a little bit harder to maintain those BMIs. So about 50% of the population would meet criteria for being overweight or obese. We have a higher waist to hip ratio. We have an increased risk of insulin resistance and high blood pressure. And about 1/4 of children and 1/2 of young adults may also have lipid abnormalities, so cholesterol and triglyceride abnormalities. We would also potentially have a higher risk of sleep apnea, which also increases your risk of high blood pressure and other concerns. And then the risk of diabetes can be as high as 70% lifetime. Now, we're not, it's a little bit harder to know if an individual with Turner syndrome has type 1 diabetes or type 2 diabetes. So we are recommending with the new guidelines, that everyone check antibodies for type 1 diabetes. So we shouldn't assume that it's type 2 diabetes that we're seeing. It's also believed to be some impairment in our ability to secrete insulin, as well as to respond to insulin that's already been produced. And some studies might suggest that getting the fasting blood sugar is not enough information, and we should really be doing an oral glucose tolerance test where you take that sugary drink and then you check your blood sugars an hour or 2 hours later. That's probably a little bit more indicative of our risk for developing diabetes. And we don't really have any studies at this time that looks at what's the best way to take care or to treat diabetes in Turner syndrome. So we're using information that's just for the general population. In terms of the criteria that's in the latest guidelines, the recommendation is to start screening at the age of 10 to 12 unless you have symptoms of diabetes. I think that is it for me. Okay, thank you.